Hello everyone, my name is Daniel. I'm the co-founder of the USMLE Forum of Pakistan, and in this lecture we will talk about the hypertension. So this is the cardiology series, and this series is a continuation of the previous videos, and the previous lectures are delivered by Ritik Kiani, and from now I'll be leading on most of the lectures of cardiology series from now onwards. So first of all, if we talk about hypertension, so we have to define what it is, right? Then after telling you the basic definition of hypertension, I'll tell you the diagnostic criteria. After discussing the diagnostic criteria, we will jump on the different terms, and then we will jump on the treatment, and then you will jump on the primary, secondary, and the different causes of secondary hypertension, right? So the first of all, the basic definition of hypertension is having a blood pressure of having a systolic blood pressure of more than 130 and having a diastolic blood pressure of more than 80. So this video is exclusively for step 1 candidates, not for step 2 seeker candidates, but in this video let me tell you some additional thing. So when you see a person with raised blood pressure, you don't directly recommend them as a hypertensive. The reason why is that because you need, to diagnose hypertension, you at least need two readings, more than two readings, and at two different occasions, right? So without this, even if you are having high blood pressure, you cannot label them as hypertensive. You can say that Mr. XYZ is having a high blood pressure, but you cannot diagnose them as hypertensive, right? Then if the patient is developing an organ damage as a result of hypertension, then you can label them as hypertensive without having readings without having more than two readings at two different settings. So this is the criteria to diagnose hypertension, right? So let me tell you two different terms, which is hypertensive urgency and hypertensive emergency. Most of the students confuse between these two different terms. So how I used to remember this, that in hypertensive emergency we simply have an emergency situation. An emergency situation is only when you are damaging organs, right? So in hypertensive emergency there is an organ damage. That an organ damage can be in the form of a stroke, it can be in the form of MI, it can be in the form of uh, hypertensive retinopathy, and whatever, and etc., right? But in case of hypertensive urgency, you have a raised blood pressure, and the threshold of that is more than 180 systolic and more than 120 diastolic. You have this raised blood pressure, but still you are not having the end organ damage. So this is the criteria of hypertensive urgency, and I told you the criteria of hypertensive emergency. Again, in hypertensive emergency, you have the end organ damage no matter what the blood pressure is. Of course it would be on the higher ranges, but in hypertensive urgency you're not having any end organ damage, and the criteria of the raised blood pressure is 180 systolic or 120 diastolic. So this is the criteria I just shared with you. Now if we talk about the different, so after discussing these, having said that, now let me discuss about the primary and secondary hypertension. So keep in mind that there are many risk factors of hypertension. Hypertension is related to multiple risk factors, and it can be age, it can be smoking, it can be obesity, it can be the ethnicity, right? Like black people tend to have more tend to be more hypertensive as compared to the white people. You can check this at your own, but this is a criteria I remember. So these are the criteria to diagnose the these are the criteria of this is what primary hypertension is. So in primary hypertension you are basically having multiple risk factors, and you are not having any single identifiable cause. This is the criteria of primary hypertension. Again, let me repeat it. In primary hypertension, your patient might have CKD, your patient might have different things going on, your patient might have diabetes, your patient have many different factors, many risk factors, and many risk factors going on, but there is no specific single identifiable definable cause of that hypertension. But in terms of secondary hypertension, you have obvious secondary cause in front of you. You know what is causing this hypertension, right? You know the exact cause of that hypertension. So in simple words, in primary hypertension you don't have any identifiable cause, but in secondary hypertension you have identifiable cause. And keep in mind, primary hypertension is multifactor, but secondary hypertension is not multifactorial. Also, another thing that you should keep in the back of your mind is that primary hypertension is the cause of 90% hypertension in the overall world, whereas the secondary hypertension is actually the cause of it makes the rest of the 10%, right? So now these are the basic differences. So now up till now we have discussed what is hypertension, we have discussed these thresholds, we have discussed what is hypertensive urgency, what is hypertensive emergency, and now we are talking, and now we have done, we just talked about the difference of primary and secondary hypertension. Now, after going into detail of these things, let me jump into the direct and causes of secondary hypertension. So, the causes of secondary hypertension, there are a list of causes, but I'll focus on the main ones that you will most likely see on the exams. I'll share extra information with you, of course, but my main focus is to have an exam-oriented approach. So, the first and most common cause you will encounter in your exams is the primary hyperaldosteronism. So actually what happens in this disease, due to some underlying pathology and mostly adrenal adenoma, your adrenal gland is producing tons of aldosterone, and as a result of which you are having a lot of aldosterone in your blood. And that aldosterone, you know, the function of aldosterone increases the sodium level, and if the sodium level is increased, then ultimately the blood osmolarity increase, and if the blood is hyperosmolar, it pulls out the fluid and it increases the amount of fluid passing. And if the amount of fluid passing is increased, it means the cardiac output is increased, and if the cardiac output is increased, then blood pressure is increased. So keep in mind the formula of blood pressure, which is equals to cardiac output and total peripheral resistance. If you are increasing cardiac output, then of course the blood pressure will be increased. If you are increasing total peripheral resistance, then blood pressure will also be increased. So this is about primary hyperaldosteronism, that in primary hyperaldosteronism, due to hypersecretion of aldosterone, there is a lot of sodium, and if there is a lot of sodium, there is a lot of fluid, and if there is a lot of fluid, there is a lot of cardiac output, and if there is high cardiac output, then of course it is there is raised blood pressure, and that's what's causing the secondary hypertension. Now, let me tell you, there is a phenomenon which is called aldosterone escape. So, despite having a lot of sodium, despite pulling a lot of fluid, the body remains in the euvolemic state. The reason is that when you are pulling a lot of fluid, and when the heart is accepting a lot of fluid, then the atrial muscle stretches, and when the atrial muscle stretches, they release some peptide, and the one which is most important for us is atrial natriuretic peptide, ANP. This ANP actually excretes a lot of sodium from in your urine, and that leads to sort of diuresis, and if there is diuresis, there is again you're losing the fluid, and your body is in euvolemic state. Alright, so this is about the primary hyperaldosteronism. Now, another cause of secondary hypertension can be something called as, so okay, let me talk about the treatment. The treatment of course primary aldosteronism will be the potassium sparing diuretic, and among those, the one which you should remember is spironolactone, because it is an aldosterone antagonist. Now, simply work by blocking the function of the aldosterone. So this is about the primary hyperaldosteronism. Now let's talk about the another cause of hypertension, the another cause of secondary hypertension, which is the Liddle syndrome. In Liddle syndrome, there is hyperactivity of epithelial sodium ini-cet channel. These channels are present in the distal convoluted tubule. No, they are present in collecting duct, and the main function of these ini-cet channel is just to reabsorb sodium, right? So these are the similar channels on which the aldosterone works. So in this case, the patient will have sort of similar picture to the hyperaldosteronism, but the blood in the blood, if you see the serum levels, the serum aldosterone levels will be down as a result of the feedback mechanism, but the sodium levels will be high, and the blood pressure will be obviously high. So of course there will be no aldosterone escape mechanism in this case, because this condition is not due to the increased production of aldosterone. Anyways, leave that. So I give you the blood picture of this situation, and for the treatment purpose, you will go for the um, the amiloride, because amiloride is ini-cet channel inhibitor, ini-cet channel blocker. So amiloride is also potassium sparing diuretic, just like your friend aldosterone, right? So again, in this way, the amiloride will get rid of the high sodium levels in your blood, right? So let me tell you the basic things. Since you know the function of aldosterone, so in both of these states, in a little syndrome as well as in the hyperaldosteronism, you will have high sodium levels in your blood, and you will have the low potassium level in your blood, because the function of aldosterone and the function of course, the ini-cet channel is to increase the sodium levels in your blood and to excrete out the potassium out of your blood, right? So this will be out of your body, and of course in the urine. So this is about the Little syndrome, and this is about the hyperaldosteronism. Now another case in which you can have the high blood pressure, and then the cause of secondary hypertension is very commonly asked in the exam, frequently asked in the exam, which is pheochromocytoma. Keep in mind the correlation of pheochromocytoma with MEN syndromes, right? Multiple endocrine neoplasia. You will have a separate lecture on that. So in case of pheochromocytoma, you are having a medullary tumor, and as a result of that tumor, you are producing a lot of catecholamines and a lot of epinephrine and norepinephrine. And if you're producing a lot of these enzymes, as you know that these enzymes are hypertensive enzymes, and hypertensive hormone, and that will lead to they are sympathetic hormone, of course, and that will lead to the high blood pressure. So the treatment of the pheochromocytoma is, of course, you will go for the basic a very common mnemonic, the A before B. So you will try the alpha blocker first, and then you will go for the beta blocker. You don't jump to the beta blocker like metoprolol or any drug like that. In the pheochromocytoma, you first give any alpha blocker like phenoxybenzamine. You give the alpha 1 blocker, then you go jump to the beta 1 blocker. So this is how you treat the pheochromocytoma, right? First one the alpha blocker, then the beta blocker. This is management of the pheochromocytoma. Of course, this is not detailed management, because management is not a part of the step 1 stuff. When we will be discussing about a step 2 CK, we will discuss the detailed management of every single disease, right? So this is about the pheochromocytoma, and then let's jump to the another cause of secondary hypertension, which is the renal artery stenosis, RAS. So the most common cause of renal artery stenosis, especially in the female population and the young female population, or the mid-age female population, is fibromuscular dysplasia, FMD. You just have a beaded appearance of your renal arteries in such cases. And of course, since there is no blood supply, since the renal artery is stenosed, you are not providing the blood to the efferent arteriole, and there is no blood to the efferent arteriole, there is no blood to the nephron, and the macula densa cannot sense the blood. And if it's not sensing the blood, take it as that the blood is having very low level of sodium, so it starts secreting the renin, and the renin-angiotensin system works. It works fast, it ramps up, and as a result of that, you are again reabsorbing a lot of sodium, and then a lot of fluid, and then again the cardiac output is increased, and the patient is having hypertension. So this is about the most common secondary causes that you will most likely encounter in your exam. Another cause of secondary hypertension is CKD. In case of CKD, you are actually having your kidneys are worn out, your kidneys are not working well. If your nephrons are worn out, if your nephrons are not working well, then simply you are not having enough GFR. If you are not having enough GFR, then you cannot provide enough blood to the macula densa. If you're not providing enough blood to the macula densa, again you cannot sense your macula densa ramps up the renin-angiotensin-aldosterone system, and that leads to the hypertension. Another cause is simply the sodium retention. Since your kidneys are not working well, they cannot excrete out the sodium, and of course, as a result of that, you're also having the high blood pressure. So these are the most common secondary causes of the hypertension. So in case of secondary hypertension, of course, you have to treat the secondary cause first. You have to give the underlying management, you have to treat it accordingly, you have to give the antihypertensive, but along with that you have to treat the underlying cause of the hypertension, the underlying cause of which of the disease, right? The underlying disease which is causing hypertension, you have to treat it first, then you jump to the then of course hypertension will be managed once the disease is over, or it is once it is resolved. So these are the causes of secondary hypertension, and we have discussed it in detail. Now there are few side effects, not you can say side effects, there are some effects of the hypertension on the system, on your whole body. And of course, since you are having a lot of blood pressure, then your heart is pumping, heart is doing a really tough job. It is uh, uh, it is pumping against a lot of blood pressure. Since you know, if the blood pressure is increased, then the afterload is increased, and the strain on the heart is increased. So if the heart is undergoing this stress, it undergoes the concentric hyperplasia, and that leads to concentric hypertrophy of the heart. Upon the ECG, it shows a high spike ECG. It shows a very notched and high voltage ECGs, and upon and of course yeah, and upon the auscultation you can hear the S4 sound on the auscultation. So these are the causes of the hypertension, and these are the side effects of hypertension. Now there is these are the effects of hypertension in your body. Now there is a term which is called as arteriolar rarefaction. So the arteriolar rarefaction simply means that you are having such raised blood pressure that your arterioles are worn out, and you cannot appreciate your arterioles in your blood vessel system. So this wraps up our discussion of the hypertension. Now there are a few terms. Well, these are very common things. First of all, you should know what do you mean by compliance of the vessels. So this will help you to understand that why increase in age leads to increased hypertension. Sorry, increase in age is a risk factor of hypertension. So there is something called as compliance of blood vessel, and that is the formula of that is written here. C is equal to delta V upon delta P. Delta V is the change in volume over the change in pressure. So what actually happens is that the more you decrease the compliance of the blood vessels, the more you are having the high blood pressure, or the more you are having the difference in the pressures, the more you are having the pulse pressure. Let me explain you why. So let's just explain it by some theoretical way, then you can see it mathematical as well. So first of all, you know, the compliance of vessels simply means how elastic the vessels, how stretchable the vessels are to the stress. So if you are decreasing the compliance of the blood vessels, remember the systolic blood pressure is actually a measure of the force by the blood cells on the arterial wall. Now if you are applying a force on a soft and compliant vessel, then the documented force will be less. It's a very understood and basic thing. For suppose there is a wall, and that wall is soft or is made of rubber, so the force that I'll be applying on that wall will be less, right? So that's why the more the compliant vessel is, the less the systolic blood pressure is, right? So that's why if the blood vessel is, now let's take a different scenario. If there is a wall that is made of a brick, and if I apply my hand, if I give a punch to that wall, the force will be large, the force will be maximum, the magnitude of force will be high. The reason is that because it's less compliant, right? So that's why if the blood vessel is a less compliant one, then you are having the high systolic blood pressure, right? At the same time, keep in mind that the diastolic blood pressure is actually the measurement of the compliance of the vessels. The more the vessel is compliant, the more the diastolic blood pressure would be, But in this case, if your blood pressure is not compliant, if your blood vessel is not compliant, then your blood pressure would be low. Sorry, your diastolic blood pressure would be low. So that's what leads to the difference of delta, the difference of systolic blood pressure and the diastolic blood pressure. And the difference of systolic blood pressure and diastolic blood pressure is actually the pulse pressure, right? So this leads to the difference in these parameters. So in case of if when you are going toward when you are aging, so your compliance the compliance of the vessels is decreased, and that's why your systolic blood pressure is high and your diastolic blood pressure is low, and the difference of these two blood pressure, which is the pulse pressure, is high, right? That's a very simple concept. I've explained in detail. Keep in mind that the compliance is actually the measurement of the diastolic blood pressure, and that's compliant. The force on the atrial blood wall, the force on the arterial blood wall. Let me correct myself. The force on the arterial blood wall when the heart is contracting is actually the measurement of the systolic blood pressure, and more specifically, the force on the aorta is actually the measurement of the systolic blood pressure. By keeping these definitions in mind, you can simply correlate why the increase in compliance leads to the decrease in the increase in the compliance leads to the decrease in difference of the pulse pressure. So that wraps up our discussion for the different concepts of the hypertension. So the next one is what should be the treatment of hypertension. So for the sake of treatment, you should first of all go for the first line agent. Then you'll be talking about the drug of choice in the hypertensive urgency and hypertensive emergency. So keep in mind that whenever you are going for the long-term treatment of hypertension, you should focus on the you should get the most commonly used is the ACE inhibitors or ARBs. You can also choose the calcium channel blockers, and you can also choose the beta blockers. So you know the basic antihypertensive classes like beta blockers, like the ACE inhibitors and ARBs, and like the calcium channel blocker, they are commonly used for the sake of long-term management of hypertension. But in the emergency settings, for the hypertensive urgency, you use captopril, and you use the oral labetalol, and you might use the amlodipine. Yeah, you might use the amlodipine. So these are the drugs that are used in case of emergency, and especially in the case of your hypertensive urgency. Keep in mind that in hypertensive urgency, we go for the oral drug. We don't jump to the IV management. But in case of hypertensive, at times we also go for the IV management in hypertensive urgency cases when we are not managing the blood pressure orally. But you first give the captopril, and we give it orally. We place it just below the tongue and let it work, and let the God decide whatever is going to happen next. And then we have the hypertensive emergency management, and in that case we use we use IV labetalol, and we go for nicardipine, and which is a calcium channel blocker. Labetalol is alpha beta 1 blocker, and we go for IV asmolol, and these are the drugs we use in case of hypertensive emergency. So this wraps up our discussion of the hypertension. I think I have discussed the whole topic in detail. Now you can just read out this page of the first aid, and then you will get an idea of what actually I mean. And I hope that you may encounter this question on your exam, and may you end up getting the correct answer. Thank you so much.